Hello everyone. Welcome to the RRR Series for EPCOG Part 1. I'm Dr. Ujjwala, your mentor as Study Medics. Today we will be focusing here on some key topic in benign gynecology. This topic we will be covering through SBAs and EMQs so that you will get idea of how to approach these questions in the exam. So we will be covering here abnormal uterine bleeding, fibroid and fertility decision making, and ovarian cysts. So let's begin with a proverb. Winners are not people who never fail, but people who never quit. So let's begin with first SBA. 35-year-old women attend the gynecology clinic complaining of worsening heavy menstrual bleeding. Investigation have been performed in the primary care. Her hemoglobin level is 9.3 gram per deciliter and a pelvic ultrasound scan show no obvious abnormality. Question is, what is the most appropriate first-line pharmacological treatment? The options are combined oral contraceptive pills, cyclic norethistérone, dipomedroxyprogesterone acetate, LNG-IUS, or tranexamic acid. So always remember, when a woman comes to you with a heavy menstrual bleeding, the first step is to classify the cause using palm coins to see whether it's a structural cause or the non-structural causes. So LNGS, the treatment is LNGS-IUS as the first treatment for HMB when there is no identified pathology or the fibroid less than 3 centimeter in diameter or which are not causing distortion of the uterine cavity and suspected or diagnosed adenomyosis. So let's move on with another SBA. A 40-year-old woman present to primary care with an 8-month history of heavy menstrual bleeding. Her cycles are regular, 28 to 30 days. She reports flooding and passes clot during the first 2 days. She denies intermenstrual bleeding, postcoital bleeding, pelvic pain, pressure symptoms. She has no personal or the family history of bleeding disorders. Examination is normal and the uterus is normal size and non-tender. What investigation should be undertaken? So remember, whenever any woman comes with a heavy menstrual bleeding, the first step is to do the hemoglobin to check whether she is anemic or not. So here the answer is full blood count has to be done in parallel with the treatment provided for HMP. Why the other causes options are coagulation screen, endometrial biopsy, pelvic ultrasound, serum ferritin. Why these are less appropriate? Because coagulation screen we are doing only when there are suspected coagulation disorder, like example, von Willebrand disease, or who have had heavy periods since menarche. Endometrial biopsy can be done if the initial investigation does not relieve any causes or suspected features. Serum ferritin we do generally offered for women with a heavy menstrual bleeding. We don't routinely do for the patient with the HMP. Pelvic ultrasound can be done if there is a palpable abdominal mass, or vaginal examination reveal the pelvic mass of uncertain origin or pharmacological treatment fails. So ultrasound is the first line diagnostic tool. So answer is full blood count. Moving forward with another SBA. 49-year-old woman present to the gynecological clinic with heavy menstrual bleeding and dysmenorrhea. She reported that her menstrual flow has progressively increased in volume over the recent month, accompanied by significant cyclical lower abdominal pain. She denies any intermenstrual or postcoital bleeding. There are no symptomatic symptoms such as weight loss, fatigue, or fever. She is otherwise fit and well. Pelvic examination is unremarkable. She is not keen on hormonal method of treatment. So what treatment would you initially recommend? Remember, the options are danazol, ethamselecte, mafenamic acid, norethistérone, and tranexamic acid. And see the question that she is not keen on the hormonal methods of treatment. So here the danazol and norethistérone are out. The remaining options are ethamselecte, mafenamic acid, and tranexamic acid. Ethamselecte is less accurate for controlling the heavy menstrual bleeding, and guideline is not recommended at the first line therapy. So out of the option, what remaining is mefenamic acid and tranexamic acid. Out of this, mefenamic acid would be the correct choice if the woman is having heavy menstrual bleeding and dysmenorrhea. A 55-year-old postmenopausal woman is referred to the postmenopausal bleeding clinic following an ultrasound arranged by her GP for abdominal bloating. The scan shows cystic spaces within the endometrium and an endometrial thickness of 15 mm. She has previously used tamoxifen for 5 years for breast cancer and she reports no vaginal bleeding. Question is, what is the best management option? Options are do nothing as she did not have any bleeding, high dose of oral progesterone, hysteroscopic and endometrial biopsy, Mirena or MRI. So remember, whenever the women with the postmenopausal bleeding and who previously used the tamoxifen and endometrial thickness of 15 mm with some cystic spaces, so correct answer is the hysteroscopic and endometrial guided biopsy, as hysteroscopic allows the direct visualization and targeted biopsy, making it most appropriate investigation. We'll move forward with another SPA. 32-year-old woman present to the gynecology clinic with 1 year history of heavy menstrual bleeding. Her cycles are regular, occurring every 28 days and lasting 6 to 7 days. There is no intermenstrual or postcoital bleeding. Pelvic examination and ultrasound scans are normal. She wishes to avoid hormonal therapy and would prefer a non-hormonal treatment option. You prescribe tranexamic acid to be taken during menstruation. The question is, tranexamic acid belongs to which one of the following pharmacological group? These are the options. The correct answer is tranexamic acid is an antifibrinolytic agent, and this reduces the blood loss by approximately 40 to 50%. We'll move on with the EMQs. So here, always see the instruction. You have to choose here the single most appropriate management. So we'll start with the scenario. A 32-year-old nulliparous woman present with a 1 year history of heavy menstrual bleeding associated with progressively worsening dysmenorrhea. She complains of cyclic localized pelvic pain that starts shortly before menstruation and improves after bleeding begins. She also reports deep dyspareunia. There is no intermenstrual or postcoital bleeding. Clinical examination is normal, and a transvaginal pelvic ultrasound scan show no abnormality. So here the symptoms suggestive. Here the symptoms suggestive of endometriosis. So laparoscopy is a gold standard for diagnosis, allows biopsy if needed. MRI pelvis is the second line only for the suspected deep infiltrating endometriosis. We'll start with another SPA, another EMQs. So 41-year-old woman present with an 8-month history of heavy menstrual bleeding. She reports passage of the clots and prolonged bleeding lasting 8 to 9 days. There is no intermenstrual or postcoital bleeding. On examination, the uterus is slightly enlarged but mobile and non-tender. What is the first line investigation to identify the structural pathology in this patient? So first line investigation for identifying any structural causes of heavy menstrual bleeding is the transvaginal or transabdominal pelvic ultrasound, which can detect the fibroid, adenomyosis, endometrial polyp, ovarian pathology, which is non-invasive and widely available. Hysteroscopy or saline infusion sonography is the second line and used if ultrasound suggests intrauterine pathology. Endometrial biopsies indicate only when the woman is 45 years or with the risk of malignancy. We'll see with the next set of EMQs. A 43-year-old para 2 women with a BMI of 46, present with a 2-year history of heavy menstrual bleeding. She underwent people endometrial biopsy, which shows endometrial hyperplasia without atypia. A LNGS IUS was inserted 2 years ago with initial improvement in symptoms. However, she now reports recurrence of menorrhagia. She has completed her family and has no other significant medical history. The question is, what is the most appropriate next step in the management? So you can see here the algorithm. Whenever there is a persistent or the progression of the symptoms, the definitive treatment is total hysterectomy with PSO. So in this patient, keeping her age in mind, she's 43 years, so ovary should be conserved. And the correct answer is total laparoscopic hysterectomy plus conservation of the ovary. Next scenario, a 49-year-old woman with a BMI of 34 initially presented 2 years ago with a heavy menstrual bleeding. Endometrial sampling at that time confirmed endometrial hyperplasia without atypia. She was managed conservatively with insertion of LNGS IUS, and she has been compliant with the follow-up and underwent endometrial surveillance with papal biopsy every 6 months. The 2 consecutive biopsies taken 6 months apart have shown normal endometrium with no evidence of hyperplasia. She is currently asymptomatic and reports good control of her bleeding. So what is the most appropriate next step in her management? Always see her BMI is 34 and the 2 consecutive biopsy which is done 6 months apart are negative. So we'll see the algorithm here. Whenever the BMI is less than 35 and 2 consecutive negative endometrial biopsy at 6 months apart, patient can be discharged from the endometrial surveillance. So this is the answer. We'll move on with the next scenario. A 39-year-old nulliparous woman present with a history of heavy menstrual bleeding over the past several months. She has no significant past medical history and is otherwise well. She is keen to conceive in near future. Endometrial sampling with papal biopsy confirms endometrial hyperplasia with atypia. There is no evidence of invasive malignancy on imaging, and her pelvic ultrasound scan is otherwise unremarkable. She is very concerned about preserving her fertility and wishes to avoid definitive surgical treatment if possible. Question is, what is the most appropriate next step in the management? To see the question, the patient papal biopsy confirms endometrial hyperplasia with atypia, and the woman is concerned about preserving her fertility. So here the LNGS IUS provide the effective local progesterone treatment, and the repeat endometrial biopsy should be performed every 3 months to confirm the regression before attempting the conception, and the close follow-up is essential. You can see here. So we'll start with the next topic, that is leiomyoma. Fibroid. A fibroid is so we'll start with the SPA. A 38-year-old woman present with a 1-year history of heavy menstrual bleeding. She denies intermenstrual bleeding, postcoital bleeding, pelvic pain, or pressure symptom. She has completed her family and is otherwise well. On examination, the uterus is normal in size and not tender. A transvaginal ultrasound scan shows a single 2.5 centimeter intramural fibroid that does not distort the endometrial cavity. Which of the following best describe the appropriate management category? These are the options. The correct answer is here, as per the guideline, the treatments is pharmaceutical treatment recommend for symptomatic small fibroid, which is less than 3 centimeter and not distorting the cavity. So answer is fibroid is less than 3 centimeter, not distorting the cavity and causing the heavy bleeding. Asymptomatic fibroid, regardless of the size, generally do not need intervention. Next, SPA, a 36-year-old woman present with a heavy menstrual bleeding for 2 years. Abdominal examination reveals a 20-week size uterus. Pelvic scan show multiple interstitial fibroid. Hemoglobin 9 gram per deciliter, and she is nulliparous and wishes to preserve fertility. Which management option would you recommend? Options are GnRH analog for 6 months followed by myomectomy, MRI focus ultrasonography, or open or laparoscopic myomectomy without pretreatment, ulipristal acetate. Here, always a woman with a 20-week size fibroid and which is symptomatic. So pre-treatment with GnRH agonist, which causes the shrinkage of fibroid, reduces the menstrual blood loss and corrects anemia, makes surgery severe, and reduces intraoperative bleeding, and fertility is preserved. Why the other options are not appropriate? Open and laparoscopic myomectomy without pre-treatment. I mean, myomectomy is correct as a definitive treatment, but pre-operative optimization with GnRH agonist reduces the blood loss and complication, especially with a 20-week size uterus. MRI-focused ultrasonography is a diagnostic only, and ulipristal acetate is not suitable for the long-term management of the large symptomatic fibroid with anemia. We'll see another SPA, a 24-year-old nulliparous woman present with heavy menstrual bleeding and pelvic pressure. Imaging reveals a 7 centimeter intramural fibroid. She is otherwise healthy and has completed fertility investigation. She is keen to conceive in the future and has been counseled about surgical option for fibroid removal. During counseling, she asked specifically about neurosurgical technique and wants to know how each procedure may affect her future fertility. Which of the following statement is correct? Options: laparoscopic myomectomy is associated with a lower chance of conception. Hysteroscopic resection is feasible for almost all types of myoma. Laparoscopic myomectomy is her best option. Myolysis or cryomyolysis offer the best chance of conception. Pregnancy rates are lower after laparoscopic myomectomy when compared to the open approach. So always, whenever laparoscopic myomectomy is considered the preferred surgical option as per the meta-analysis, although it has a longer operating times than the open myomectomy, but result in the less blood loss, reduce post-operative pain and fever complication, and preserve the uterus and therefore the fertility. Why the other options are incorrect? Laparoscopic myomectomy is associated with the lowest chance of conception. No, it does not reduce the chance of conception compared with the open myomectomy. Hysteroscopic resection is feasible for all types of myoma. It's only for the submucous fibroid we can do hysteroscopic resection. Intramural or the large fibroid are not amenable. Myolysis and cryomyolysis offer the best chance of conception. This technique may damage the surrounding tissue, increases the adhesions, and have less predictable fertility outcome. Pregnancy rates are lower after laparoscopic myomectomy compared to open. Meta-analysis shows there are comparable or even the improved reproductive outcome after the laparoscopic myomectomy, with addition perioperative benefits. We'll see another SPA. 32-year-old nulliparous woman present to the gynecology clinic with the heavy menstrual bleeding for the past 8 months, associated with the mild pelvic discomfort. She is otherwise healthy and is keen to have children in the future. Transvaginal ultrasound demonstrates a 5 centimeter grade 0 submucous fibroid entirely within the endometrial cavity with no other uterine or adnexal pathology. She has tried medical management with NSAID and tranexamic acid, but continues to experience significant menstrual blood loss affecting her quality of life. Question is, which of the following management option is the most appropriate for her? As you have seen that here the fibroid is submucous and which is grade 0. So it is totally in the cavity. So out of this option, LNGS, IUS, hysteroscopic fibroid resection, uterine artery embolization, GnRH analog, or the hysterectomy, the correct option is hysteroscopic fibroid resection, which provides a symptomatic relief from her heavy menstrual bleeding, improves the chance of conception by restoring a normal endometrial cavity, which is minimally invasive with quick recovery. We'll see another SPA, a 42-year-old woman present to the emergency department with fever, nausea, vomiting, and foul smelling vaginal discharge. 2 weeks earlier, she underwent uterine artery embolization for symptomatic fibroid, which is 18-week size, and she appears unwell, and infection of a necrosed fibroid is suspected. Which investigation is the most appropriate to guide the further management? Options: CT scan of the abdomen and pelvis, hysteroscopy, MRI of the abdomen and pelvis, transabdominal ultrasound, and transvaginal ultrasound. Here, the patient is presenting after the uterine artery embolization. That means it is a post embolization syndrome. So, MRI with contrast is the best investigation which identifies partially infracted or necrotic fibroid, detect the infection or the abscess formation, helps differentiate the post embolization syndrome from the true infective complications. We'll move on with the EMQs. And here the instruction you just see, that is to choose the most appropriate management options. So we'll start with the first EMQ from this section. 35-year-old woman present to your clinic complaining of heavy menstrual bleeding for the past year. She reports that her periods last 7 to 8 days and require frequent pad changes. She experienced some fatigue but denies intermenstrual bleeding, pelvic pain, or pressure symptoms. She and her partners are planning to conceive within the next year. Her medical history is unremarkable and she has no prior surgeries. On examination, her abdomen is soft with no palpable masses. Pelvic examination reveals a slightly enlarged, non-tender uterus with no adnexal abnormality. Transvaginal ultrasound shows 3 intramural fibroids, each measuring 2 to 3 centimeters. And she asked about the treatment option to reduce her menstrual bleeding while preserving her fertility. So, as the patient wants to conceive and start her family soon, so here the conservative management should be the correct option. So, we can offer her tranexamic acid, will help to reduce the HMB, and myomectomy is generally not indicated for the fibroid less than 3 centimeters. Next EMQ. A 39-year-old woman present with heavy menstrual bleeding for the past 6 months. She reports soaking through pads daily and occasionally passing small clots. She is unsure when she wants to start a family, but would like a treatment that definitely controls her bleeding. On examination, the uterus is mildly enlarged but not tender. Transvaginal ultrasound shows a single submucous fibroid measuring 4 centimeters, projecting into the endometrial cavity with no other abnormalities are noted. So, submucous fibroid with a size of 4 centimeters projecting into the endometrial cavity, the hysteroscopic myomectomy will offer the definitive management for her, and pregnancy is not indicated after the hysteroscopic myomectomy. Next scenario. A 45-year-old woman present with the heavy menstrual bleeding for past year. She reports soaking through multiple pads daily and experiences occasional clot. She has a known history of cardiac arrhythmia and had a pacemaker inserted 3 years ago. She does not wish to undergo any invasive surgical procedures. On examination, the uterus is enlarged and irregular. Pelvic imaging shows multiple intramural fibroids, some of which distort the endometrial cavity. There are no adnexal masses. She is perimenopausal and has no contraindication to the medical therapy, except for her desire to avoid surgery. Which of the following is the most appropriate management? So, as she is a perimenopausal, so LNGOs can be offered, but the fibroids are distorting the cavity, hence it cannot be fitted. MRI, magnetic resonance guided focus ultrasound, is another option, but cannot offered her due to the cardiac pacemaker. Hence, uterine artery embolization is the best choice available for her. We'll see another set of the MQs. Here we have to choose the next most appropriate intervention. So, a 44-year-old woman is known to have a heavy menstrual bleeding and uterine fibroid. She has had regular period while on combined oral contraceptive pills and tranexamic acid for the last 2 years, but her periods have recently become erratic. She has a 14-year-old child with special needs, and being a single parent, she finds it difficult to take care of him. Her general practitioner requests a scan which shows 3 intramural fibroids, the largest measuring 6 centimeters. On examination, her uterine size is 15 weeks of pregnancy. So here you can see, although the fibroid can cause the irregular bleeding, her age is more than 40, but the recent change of the bleeding pattern, like you can see, recently become the erratic. So that's warrant the evaluation for endometrial biopsy pathology. So endometrial biopsy is the correct option for her. Move on with another scenario. A 48-year-old woman present with a menorrhagia and 24-week size uterus with multiple fibroid. Ultrasound shows variable size intramural fibroid. She has opted for uterine artery embolization. Apart from hysteroscopy, what investigation is necessary? Prerequisite before performing the uterine artery embolization. So MRI is essential for detailed mapping of fibroid number, size, location, and vascular supply. So MRI pelvis is the correct options for her. We'll move on with another subtopic, that is the ovarian cyst. The first SPA, 56-year-old postmenopausal woman is referred to the gynecology clinic after an incidental finding of an unilateral ovarian cyst on pelvic examination. She is 6 years postmenopausal and denies abdominal pain, bloating, early satiety, or weight loss. She has no significant past medical history and no family history of ovarian or breast cancer. On examination, her abdomen is soft and non-tender. A transvaginal ultrasound scan is performed. The cyst is unilateral and further morphological assessment is undertaken. Which of the following ultrasound feature would be considered suspicious for malignancy? Options: an ovarian cyst over 10 cm in maximal diameter, the presence of acoustic shadowing, no blood flow, or regular multilocular 8 cm cyst, or a smooth multilocular 3 cm cyst with calcified areas. As per the IOTA, classified benign and the malignant, whenever a cyst of more than 10 or more is considered as a suspicious feature for malignancy. Next SPA, a 64-year-old postmenopausal woman is found to have a 4 cm ovarian cyst on a transabdominal scan performed for suspected gallstone. The contralateral ovary could not be visualized due to bowel gas. The cyst is an incidental finding. She is anxious about ovarian cancer. Which of the following investigation is most appropriate to further evaluate the ovarian cyst? So remember, here the patient is postmenopausal. So as per the algorithm, any postmenopausal women with ovarian cyst of 1 centimeter or more, the next step is to do the transvaginal or transabdominal scan and CA125 to calculate the MRI. So here the correct answer is transvaginal ultrasound plus CA25 to calculate the RMI. We'll move on with another SPA. A 32-year-old nulliparous woman is found to have incidental 68 mm simple left ovarian cyst on pelvic ultrasound scan. She is asymptomatic, has a regular menstrual cycle, and wishes to avoid the surgery. The cyst is unilocular, thin-walled, anechoic, and shows no solid area or abnormal Doppler flow. What is the most appropriate management provided she remains asymptomatic? So option is immediate admission for emergency laparoscopic ovarian cystectomy, elective admission for laparoscopic ovarian cystectomy, repeat ultrasound scan in 6 to 8 weeks, repeat ultrasound scan in 3 months, or the 12 months. As per the guideline, the simple ovarian cyst of 5 to 7 mm in asymptomatic premenopausal women can be managed conservatively with follow-up ultrasound in 12 months. Surgery is only indicated if the cyst becomes symptomatic, when there is a pain, torsion, or pressure, or the patient prefers definitive treatment, or the cyst has a complex or the suspicious features. Next is PA, a 28-year-old nulliparous woman with a known 5 cm ovarian cyst present at 11 weeks gestation with sudden right lower abdominal pain, nausea, and vomiting. Ultrasound shows a viable intrauterine pregnancy and an enlarged right ovary with reduced Doppler flow. She undergoes emergency diagnostic laparoscopy, which confirms ovarian torsion. The ovary appear congested but viable, and detorsion with cystectomy is performed. Histological examination of the cyst is most likely to show which type of the cyst. Options: cystadenoma, dermoid cyst, endometrioma, serous ovarian carcinoma, or the simple ovarian cyst. Here, this is the most common ovarian cyst found in the pregnancy is the dermoid cyst. They are relatively heavy due to the sebaceous material or the solid component. And because of this weight and the structure, they have a higher risk of undergoing into ovarian torsion. So the first trimester, especially they are occur in the first trimester and in the early postpartum period. Why the other options are less appropriate? Cystadenoma can occur in the pregnancy and is the second most common cyst, but less commonly associated with torsion compared to dermoids. Endometrioma less common in pregnancy due to the suppression of endometriosis by progesterone. Serous ovarian carcinoma rare in this age group and uncommon in pregnancy. Torsion is not a typical presentation. Simple ovarian cysts, the functional cysts are common but less frequently associated with torsion compared to dermoids. Next, SPA. A 64-year-old postmenopausal woman undergo the transvaginal ultrasound scan for pelvic discomfort. The scan reveals a 4 cm right ovarian cyst and that is multiloculated and contain a solid area. There is no evidence of ascites. The left ovary appear normal. Her serum CA125 level is 50 and her RMI index is calculated to be 450. Her question is, what is the most appropriate management? Option: laparoscopic and bilateral salpingo-oophorectomy, laparoscopy and right-sided salpingo-oophorectomy, or laparoscopy and staging procedure, MRI abdomen pelvis, or PET scan. So whenever the woman with a postmenopausal with such a high RMI of more than 40, so her laparotomy and staging procedure would be the correct option here, including touch with BSO and intrapolic omnectomy. We'll start with the EMQs. Here we have to choose the single most appropriate diagnosis. So a 17-year-old girl present with a sudden onset right lower abdominal pain for 9 hours. The pain is severe, intermittent and radiate to the right thigh. She has vomited twice. There is no vaginal discharge and or abnormal bleeding. Examination shows right iliac fossa tenderness and adnexal tenderness. Ultrasound reveals an enlarged ovary measuring 6 cm. So question is, which of the following is not included in the clinical scoring system for adnexal torsion? So remember, the torsion scoring system is mainly clinical. It includes vomiting or unilateral abdominal pain in this patient, and pain more than 8 hours, absence of leukorrhea menorrhagia, ovarian cyst more than or equal to 5 cm. But ultrasound morphology, such as a septation, is not a part of a scoring system. Next scenario, 26-year-old woman present with sudden sharp left iliac fossa pain. Her last menstrual period was 3 weeks ago. Pregnancy test is negative. Ultrasound shows normal uterus and ovary with a small amount of free fluid in the pouch of Douglas. What is the most likely diagnosis? So you can see here that is a typical timing during the luteal phase timing. So here, most commonly the diagnosis is the functional cyst rupture. And torsion is unlikely here as there is no enlarged ovary is seen. And there is a negative pregnancy test. We'll start with another set of EMQs. We have to choose here the most appropriate management. 64-year-old postmenopausal woman present with an abdominal distension. Ultrasound demonstrate a multiloculated ovarian cyst with solid area and ascites. Her CA125 is 125 international unit per ml and the malignancy is suspected. Which of the following imaging modality is most appropriate as a next step for her staging? So you can see the question, how they ask the question, most appropriate next step for the staging. So the answer is CT scan. CT scan is the first line imaging modality for staging ovarian malignancy. But MRI is mainly used for the tumor characterization, not routine staging. And CT, it's reserved for recurrence or the equivocal cases. And transvaginal ultrasound or abdominal ultrasound are the diagnostics tool, but they are not the staging modality. Even the X-ray has no role in the ovarian cancer evaluation. Next EMQ, a 58-year-old woman present with a weak abdominal discomfort and bloating. She has a history of hypertension and pacemaker inserted 3 years ago. She has a cochlear her clinician, she has a cochlear implant for hearing loss. Her clinician considered imaging to evaluate her abdominal symptoms and rule out potential pathology. Which of the following imaging modality is contraindication and should not be used in her case? So always remember that MRI uses the strong magnetic field that can interfere or damage the non-MRI compatible devices such as a pacemaker, cochlear implant, and certain metallic implant are at risk. And that could lead to the device malfunction or serious complication. So it is strictly contraindicated. Other modalities such as the CT scan, PET-CT, transvaginal ultrasound or abdominal ultrasound, Doppler ultrasound, X-ray, they are generally safe and can be used. The last EMQ, a 25-year-old paraben woman present with a sudden onset severe left-sided pelvic pain and vomiting for 12 hours. Ultrasound shows a 7 centimeter with reduced Doppler probe. Laparoscopy confirms ovarian torsion with a 2 centimeter cyst and the ovary appear congested but viable. What is the most appropriate surgical management? So here, in any women with the reproductive age group, always the ovary preservation is recommended. Detorsion often restores the ovary functions. So oophorectomy or salping oophorectomy is only indicated if the ovary is necrotic or malignant. Salpingectomy alone is unnecessary if the tube and the ovary are viable. Conservative management only is unsafe as torsion and can lead to the ovarian malignancies. I hope this session helps you and thank you for listening.